Hi, I'm Carol Potter, and today I would like to talk about neonatal cholestasis. One of the questions that always comes up in many of the phone calls we get is, when should you evaluate? And the guidelines say that any baby who's still jaundiced at 2 weeks of age, who's formula fed, should have an investigation done. Or a breastfed infant at 3 weeks of age. It should be done sooner if any red flags are present. In this case, red flags would be a sick infant, a baby with pale stools, a baby who's dysmorphic or has hepatosplenomegaly, a baby that has heart disease, or a baby with small penis, which would indicate that panhypopituitarism may be an issue. So where do you start? I think the first thing to do is make sure you fractionate the bilirubin. Don't just get a total bilirubin. Unfortunately, too many babies with liver disease get blown off as breastfed jaundice, and they never get a total and direct bilirubin. The next thing is to check the newborn screen. It usually is back, and if it is not, I have gotten them to run the newborn screen that same day, and you can get the results expedited if you're really worried about a metabolic disease. They're really helpful in doing that. And then the next question is, how does the baby look? Is this a sick infant, or is this more like my grandson curled up there in his blanket, who looks happy, healthy, and doesn't have a care in the world? The other thing that I think we need to think about is what needs to be done right away when you get that phone call. So what do I need to do tonight, and what can wait? And by wait, I mean wait till tomorrow. So we make it a routine practice to see babies the same day we hear about them, if we possibly can, and if not, we see them the next day. So the things that we need to worry about right away are sepsis and urinary tract infection, because that baby could get sick really quickly. You also need to think about metabolic errors that we could do something about. Hence, do you have the newborn screen back? So if you don't have a newborn screen back and you have a baby with a direct hyperbilirubinemia, you can't keep giving them breast milk because it has galactose in it. So the baby needs to be on a non-galactose formula until you figure it out, because those babies can get exceedingly quickly very sick. Fructose is also a sugar that can make you sick very quickly, and you need to do a careful diet history and make sure that the baby isn't on a fructose containing formula or one that has supplements. So maybe they've gotten Tylenol, or they're getting gripe water, or getting some other medicine that has fructose in it. So as a routine practice, we put any baby that we don't know the newborn screen on or has been exposed to fructose on progestamil until we can get it sorted out, because currently that is the formula with no galactose and no fructose in it. Now, you always need to check with the dietitian because this can change. The next thing is, does this baby need vitamin K? They may very well need vitamin K, especially if they didn't get it in the hospital. babies who are cholestatic can very quickly get vitamin K deficient, and they have very fragile blood vessels in their head and can have intracranial bleeding. Obviously not something that you want to happen if you can prevent it with vitamin K. We also worry about thyroid disease that first day. The newborn screen only picks up hypothyroidism from thyroid dysfunction, and it doesn't pick up central hypothyroidism. And every day that you miss thyroid dysfunction causes CNS issues. So we always send thyroid studies on the first day. And then if they haven't been obtained, we also get the rest of the liver tests. It's really hard to make a judgment on just a bilirubin. You need transaminases and you need a GGT and probably an ALK-Phos as well. You should also always ask the mom about the color of stool pigment. And sometimes people think that acolic stools are yellow. And so I usually try to point to things in the room that would be the color of an acolic stool, such as light wood furniture or something like that. Now, that's what you need to do at the very initial phone call. And then the next things that we worry about is anatomy issues. And so this baby is going to get an ultrasound to look at the anatomy of the biliary tree, and that usually can be done the next day. And then we also don't always the first day test for things like alpha-1 antitrypsin deficiency because we can't do anything about it, and we can do that after we have a little bit more data. So then you have your first visit. You're going to have a set of parents who's very worried. They've probably been on the internet. They're asking if their baby needs a liver transplant, and they're really scared. So it's going to take some time. Make sure you take a really careful history, particularly about previous pregnancies or neonatal deaths that are in the family. You also want to know everything that this baby has eaten, and have they been exposed to any medicine, and were there any complications of pregnancy. On exam, you need to look at the liver and spleen. Are they big? Are they firm? Make sure you start down by the iliac crest and very gently push up. Take your time. You can do it with the baby on your lap if they're more comfortable that way, or in mom's lap, but you really need to get a good feel. If you do it quickly or push really hard, the baby's going to tense up and you're not going to get a good exam. A cardiac exam is also really important because many of the forms of liver disease are associated with heart defects. So listen to the baby's chest as well as the back, because that's where you hear peripheral pulmonic stenosis, which is the most common murmur with alagioles. And then the baby just needs a really good physical examination. Make sure that you have the results of the newborn screen and that you've checked them. That will give you a first blush on if cystic fibrosis is there, on many of the other metabolic errors, and galactosemia. And then you move on to the laboratory evaluation. One of the questions is it even the liver? And we'll go into that a little bit more, but there are other sources of bilirubin other than the liver. You'll want an ultrasound to look at the anatomy, make sure there isn't a choledochocyst, a shunt in the liver. You'll get some hint about biliary atresia if they can see a duct or a gallbladder, although you cannot rule out or rule in biliary atresia with an ultrasound. It just isn't that good. And then you need to decide what genetic studies to send. There are style issues with this, and we don't all certainly do it the same way. Some people check for alpha-1 antitrypsin deficiency with a PI type on the initial blood draw. I tend to use a cholestasis panel. It takes a little bit longer to get back, but it gives me a lot more information, and I can't change anything if I know that the baby has biliary atresia, and it probably would not stop me from doing a cholangiogram and a liver biopsy, since even if it's positive, most babies who are alpha-1 ZZ don't have liver disease, so there will always be the question, is there something else? So genetic studies need to be sent, but depending on what you're worried about, they may vary as to what you actually send. So now I'd like to go over 3 cases. The first is a 3-week-old healthy baby who has a completely normal exam. You can feel a nice soft liver edge right at the costal margin. There's no splenomegaly. The baby looks great, except they're jaundiced. You got labs the day before, and you know the transaminases are normal, so no liver inflammation. The GGT is totally normal, so it doesn't look like this baby has cholestasis or buildup of bile acids in the duct, but the baby does have a direct bili. So this is a case of UTI. So infection, particularly the organisms that cause urinary tract infections, down-regulate all the transporters of bile acids, and they also down-regulate the transporter of bilirubin. So if you see a baby with totally normal liver tests and a normal liver exam, but has a direct hyperbili, urinary tract infection is a likely possibility. And we get a urine culture on every first visit. So next is a 5-week-old jaundiced infant. He's been falling off the growth curve as far as weight gain goes a little bit, but he still looks well-nourished. He's got a firm, big liver, and his stools are pale. The transaminases show some hepatocyte injury and inflammation, and the GGT is high. This indicates that there are bile acids that are sitting in the bile duct that aren't going out. And then you look, and the baby also has a direct bili. You got an ultrasound, and they couldn't see the gallbladder. So this baby has a lot of red flags for biliary atresia, and the baby is already 5 weeks old, and you really want to get a Kasai done if you have to. At our institution, we're very fortunate because we can combine a cholangiogram with a liver biopsy. So this is a baby that doesn't have biliary atresia, but the radiologist has put a needle in the gallbladder and injected, and you can see the common hepatic duct, the left and right duct, and then you see contrast go into the duodenum. if you can't get a cholangiogram, you can do a biopsy, and if it suggests biliary atresia, but that can often be difficult to interpret, then the baby needs to go to the operating room to get an open cholangiogram and proceed on to the Kasai procedure. Obviously, being able to do the cholangiogram without having to open the abdomen can certainly save babies a trip to the OR, and we are really lucky to have that. The final case that I wanted to talk about is another 5-week-old. This baby has exceedingly poor growth and jaundice. Again, has a hard liver, has a normal ultrasound, has transaminases just like the last set, but the GGT is really low in face of a direct bili. And this is a really important finding to have a low GGT. Let me explain why. This is a cartoon of a bile duct with little proteins of GGT hanging in the bile duct. Bile acids are detergents. They dissolve fat. Well, they also dissolve the protein of the GGT. So if you have bile acids in your bile duct, they're going to dissolve some of that GGT off the duct, and it's going to go into your serum. So the implication is if you don't have GGT, do you not have bile acids in the bile duct? So the reasons for having low GGT, and these are primarily pediatric diagnoses, is first, you can't make bile acids, so you have a bile acid synthetic defect. These are really pretty rare, but they certainly occur, and they can be diagnosed by urine bile acids. The next more common reason would be that you can't transport the bile acids that you have made into the duct, or bile acid transport defects. We call these PFIC, or progressive familial intrahepatic cholestasis. These are much more common than the synthesis defects, and we also sometimes call low GGT cholestasis, but it certainly sends you down a completely different pathway, which is why the GGT is so important. I'll also mention that premature babies don't have elevated GGTs because they simply don't synthesize very many bile acids, and they also have low transporters because these are developmentally regulated. So the bottom line for neonatal cholestasis is you absolutely need to do this quickly, and you need to take it seriously because you want this beautiful little package to turn out healthy. Thank you.